Good afternoon, dear friends, and thank you, Sujata, for inviting me to this IC. This is a presentation which some of you all may have seen in the previous IC. I had to give it because one of my colleagues, co-instructors, had not turned up. So it may be a repetition for some of you all. These are a few of the cases where we have had problems with Smile and then how we manage them. I've been doing Smile, mainly converted to Smile from the past 2 years. Hardly do LASIK now because I find that is a better technique. So this is the first, I am a consultant to Carl Zeiss. This is, the first case is something that happened, you can see here, after the suction with the Visumax, there is a little bit of prolapse of the conjunctiva. I have proceeded with the laser, that's the spiral in, refractive cut, side cut and the spiral out cut. When conjunctiva prolapses, like the superior conjunctiva especially, can be loose in some of these myopic patients, then it can actually mask and prevent the incision from happening, and you may have a problem. So if you see that the conjunctiva is prolapsed, once you put on the suction, it's better to release the suction and redock, applanate more firmly. Here I try to open the incision, as you can see that the incision is not fully made and it's very difficult. After some time I'm able to just enter in with a very small opening, less than 1 millimeter, and then I was wondering whether I should extend this, but then I decide, let's see if we can actually extract this lenticule through this micro incision. So this is the dissection of the superficial plane. Very important is when you have a small incision like that, that you use a windshield wiper kind of a movement with a pivot at the incision so that you do not tear the incision or damage the incision. That's the deeper plane. You can go and then dissect the deeper plane. You can see that I have marked the 0-180 degree. I routinely do this for cylinders for compensating for cyclotorsion. This was 5.5 diopter myope, so the lenticule is moderately thick. Once you're sure that it is totally free, then you can go in and grab it with a microforceps and try to pull it out. You can see that the incision is small, the lenticule gets stuck in the incision, but with a wriggling side to side movement, you're able to actually extract this lenticule through a sub 1 millimeter incision. So you can do micro Smile through a sub 1 millimeter incision. There's another case which is similar, which I have done that 1 millimeter Smile. So I think the company should provide us facility to do that. This is a patient who underwent Smile for a low refractive error. Intra-op there was a difficulty, and then surgeon had to abandon the procedure. This was the pre-op topography. You can see that it's suitable case. This is the right eye. And then post-op, after 10 days, I saw him. I was traveling. I couldn't be there. One of my surgeons was learning Smile. And this, you can see the vision was less than 6/60, very irregular cornea. You can see that it's thicker inferiorly. And patient was very unhappy. Surgeon was very apprehensive. Did an OCT, and you can see that the lenticule has all crumpled up and is in the inferior aspect of the pocket there, and you can see the epithelial thickness also is very thick inferiorly and thin superiorly, and you can see the lenticule in the pocket there. The surgeon said that he had dissected it, but then he was unable to remove it. Even on slit lamp, on careful examination, I could make out crescent shaped tissue which was there, a small bulge. So I decided to go in and dissect this nearly after 2 weeks. That's a 4 millimeter incision. This was one of his early cases. And identifying the planes, dissecting the lenticule, and then extracting it completely is very important. So what had happened here is that most probably he had pushed the lenticule down while dissecting it. The cornea had got hydrated, visibility was not very good. He tried to grab the tissue near the pupil, he was not able to get hold of anything. He said, I couldn't find the lenticule at all. So this is the dissection at the deeper plane. I separated it. It is attached inferiorly. and that's why probably he was not able to kind of remove the lenticule. After that, the superficial plane dissection is made, and once it is separated fully, you think it's totally free, then you can go in, grab it with a micro forceps and remove it. Now the whole question was whether this lenticule was intact or whether he had removed a piece of the lenticule. It was only a fragment, so you can see that you need to put some saline and then separate it out, and you can see that the entire lenticule is there, full 6.5 millimeter lenticule is there intact. So this is a case that then did very well post-operatively. The patient was 6/6 part on the first day, and the topography also came back to normal, good flattening. I'll just show you the topography. We'll close the incision. This is the post-op topography. You can see that there's a nice flattening, uniform reduction in the central thickness. So that was a case that was very interesting. Suction loss is common with SMILE because the Visimax has a low vacuum. It's a corneal suction, so the patient is still able to fixate, doesn't lose fixation. This is starting of the spiral in pattern, and there's a suction loss. The lenticule has not been cut, so the deeper plane has not been cut. When this happens, then you cannot continue with SMILE. You have to redock and convert it into a flap. The machine gives you a warning, and then you accept, and then you cut a flap, and then you can go ahead, lift the flap, and then do an excimer ablation and put back the flap. So the worst, one of the worst complications is that you convert a SMILE to a LASIK with a flap. So that's the laser ablation being done, and then you put back the flap. Patient does well. It's just like LASIK. The partial plane that is cut deeper does not really cause any refractive effect. If you have a suction loss later on in the procedure, after you have made the refractive cut, which is the deeper cut and the side cut, you can still continue with SMILE. This is a case where after docking, you can see that's the refractive cut, spiral in, that is completed, and then the side cut is done. At this stage, the light disappears, so you'll have to talk to the patient and tell them that the fixation light has disappeared, otherwise they'll search for it. When they search for it, there's usually a suction loss. You can see there's a suction loss as the superficial plane is being made. So you can actually redock, but you have to see that you center well, and then you can continue with the SMILE procedure. If it's grossly decentered, then you may have difficulty in dissecting the lenticule. So important thing here is that you have to center well, and then you can go ahead, and it's quite easy, like a regular SMILE. You do a superficial dissection and deeper dissection, and then remove the lenticule. So that was this easy to manage. You can also have lenticular tear, especially when you are doing low powers. I have done even 0.5 diopters. When you do this, you will have to increase the minimal thickness to about 30 microns. Then it's easy to do. What you can see here is this opaque bubble layer here, the white spots which are there. And when you have OBL, it can create difficulty in dissection, and there's a tendency for lenticule tears. So I completed the procedure. Identify the plane, that's the superficial plane. So what I do is on the left side, I dissect into the superficial plane, right side into the deep plane, so I know that there's a difference. Then that is the superficial plane being dissected. The superficial plane is usually easier to dissect than the deeper plane. So first dissect the superficial plane. And then you find the deeper plane. And then you're able to do a nice separation on the right side, but on the left side it's a little more sticky. That's because of the OBL. And I go ahead and try to dissect. I think I have freed most of it. And then I go in with the lenticular forceps and try to remove it. You can push it down like a rexus-like of motion and then remove it. But then after, if you have a difficult dissection, then you always have to inspect the lenticule. Or if the power is very low, then you have a thin, you can see that the lenticule is quite thin. Maybe it was like a 1.5 diopters or something, myopia. And you can see that the lower portion is missing there. So you can see that it's not a full circle and lower portion is missing there. So then you will have to go in and try to remove that piece. Even if you leave it, if it's a very small sliver, it does not actually make a big difference to the refractive effect. But you can see it on topography when you do a topography. Here I'm using the slit lamp. The Visomax has a built-in slit lamp. So with the slit lamp you can actually visualize, because you don't, the edge, when you see the edge of the lenticular cut which is there, it is not continuous. And you can see that there is that area which has not been cut. So you can go in and dissect it and release the tissue completely. And once you have released the tissue, then you can go in and grab it. Sometimes it is very thin in the periphery. This was one of my earlier cases. Now what I do is, for low myopia, I always increase the minimal thickness. You can change the value from 10 microns to 30 microns. So in a very, if you're doing like a 0.5, 0.75 or 1 diopter myopia, then you keep the minimal thickness at 25 to 30 microns. So then you do not have this problem of the thin lenticule staring in the periphery. Then you can go ahead and then grasp it with a microforceps. You remove it, place it on the cornea, and you can see that this is exactly the same kind of shape that was missing in the original lenticule. You can always also keep the original lenticule and then match it like a jigsaw puzzle. Then you can just wash the interface and then close it. Post-operatively, this patient did well. We also did a topography to check. If you have a remnant there, then you will not have uniform flattening, and in some area you can have, in the periphery, you can have a little bit of steepening, because sometimes you push this lenticule, it gets swollen up. So the first day topography you can actually make out. So on slit lamp, after the procedure, you can make out that the edge is very pristine and then clean, and you can make out the edge that's under high magnification. The refractive cut, you can actually make out the edge there. So that actually gives you an idea that you have removed the lenticule bit completely. And this is the post-op, first day post-op. You can see that this was the pre-op, sorry, this is the pre-op, and then you have the first day post-op. You can see that the flattening is quite uniform and good. You can also do an OCT and then check. Here we have asked the patient to look to the side and done the OCT in that area, and then you can see that the interface is quite clear. There's no remnant there. So with this, I think I will wrap up my session on complications of SMILE. So every procedure, this is again the thickness on ASOCT, it's uniform. So every procedure has its share of complications. I find that with SMILE it is quite easy to deal with, and all these patients who have had complications have not lost any best corrected visual acuity. So that is the best part of it. You can go in later on also and manage it even after a month or two if you have a retained lenticule, and patients usually do well. But you should be aware of the problem, suction loss, retained lenticules, lenticule tears, so that you can deal with it easily. Because SMILE is something that is coming in a big way. Patients ask for it. The procedure is growing. It's becoming more popular. All the leading surgeons, few years ago, were hesitant about it. They used to do LASIK and say femto-LASIK is best. I think including Chitra, there she's smiling. But eventually you'll have to get this because patients do ask for it. In fact, I have a DNB resident, and she did a thesis on femto-LASIK versus SMILE. End of her thesis, she decided to get SMILE and got SMILE done. So That's the kind of confidence. Thank you very much for your attention.
Thank you, Dr. Sri.